good evening to all of you who are stateside, and if there's anybody that's not, whatever time of the day, thanks for joining us. So tonight's webinar is going to be about curing composites, and it's not a really sexy topic, I can tell you that, but it's a very important part of what we do, and I'm going to get into all the intricacies and things to do and things to know, so that you can cure composites, one, better than you may be right now, and get the best use out of those composites, because that's really a critical part to this whole thing. So I'm Marty Jablow. I'm America's Dental Technology Coach. I'm doing a whole bunch of different things. I'm part of the Celrint Best of Class Committee. We pick those awards that you may see every year at the ADA, and I'm a CE leader from Dentistry Today. You get that magazine with all those pictures on it this month. But, you know, I'm a general dentist. I'm in the trenches every day. I was treating patients all day today. We'll be back in at 8 a.m. tomorrow. So, you know, basically, I'm doing what you do. And that's the important part is this isn't the theory to me. It's everyday stuff, and it's the stuff that I need to do to ensure that I treat my patients the best I can. And, you know, obviously, the better I can treat my patients, the better it is to me and my income and everything else. So if you do need to get a hold of me, whether it's on this topic or any technology topic, by all means, Marty at dentaltechnologycoach.com, or through my website or through any of those social media channels. You know, you can find me. Just a little bit of Google. And again, I want to thank Blue Light Analytics for tonight for sponsoring this event. So when you look at almost anything that's written, whether we were taught in dental school, you know, I think this part got shortchanged. And, you know, everything you read is, okay, we put the bonding agent in, we put the composite in, you layer it, you don't layer it, it's bulk fill, whatever you think it's going to be. And then it's the only thing is, and then you cure it. And that's the end of the discussion. And what I see is that even in my own practice, when I'm looking at, you know, partners and associates and others, is it's very easy to forget the things that are necessary to cure a composite properly. And with that, we get lazy, all right? And some of us cure the composite. Some of us have an assistant curing the composite. Some of us are wearing goggles, shields. Others are putting other, you know, things so that they don't look at it. Some people just look away. I mean, there's a whole bunch of stuff that goes into actually curing the composite. Yet whenever we read anything, it's, and then you cure it. End of discussion. So what we're going to be talking about today is, you know, some of these topics. I'm not going to get into real deep composite curing stuff that, you know, becomes esoteric for most of us when we talk about CQ and what nanometers it's curing at, and that. We'll get into some of these things, but I want to get into the bread and butter stuff, the stuff that's going to allow all of you to do a better job of curing your composites, and with that, you're going to get greater longevity, less sensitivities, and less breakage over time. And that's really the critical part to this whole thing. So, you know, let's get started into this and kind of work our way through. So why does proper curing matter? That's a big thing. You know, when looking through these this research, you know, we found that you know, 20% of all curing lights were out of spec. That means no matter what you did, it wasn't operating properly. And that's a lot. You know, when you think about it, you know, 1 out of 5 isn't working properly. And the unfortunate thing with curing is you don't know it. You know, as long as that composite seems hard on the top, what do you think? Well, I think it worked. So it's kind of a leap of faith. But, you know, seeing this, you're going, okay, well, 20% of them don't work properly. How am I curing? I don't know. What am I doing? What's wrong with it? You don't even know. And that's a problem. And then when you think about it even more, that half of our income comes from bonded materials. You know, whether it's a direct composite, whether it's a core buildup, whether it's bonding on a, you know, an Emax crown, all of these things, you know, come into play. And then unfortunately, we've got a 23% failure rate of bonded restorations after 2 years. Now that's a whole different discussion, you know, that we're looking at failures and failures and failures here. And, you know, that's not something we really want to be, you know, addressing. You know, we'd like to think that, you know, what we do is going to succeed on a long-term basis. But, you know, when you look at that, that's not a real good number. So what about more? All right. 30% of curing lights delivered half the energy dose required by the material. All right. So no one's paying attention because you bought the curing light. You maybe have a radiometer, maybe you don't. And as long as it lights up and cures, everybody's good. Well, that's not necessarily true. And 43% of the dentists just extend their curing times. Okay. No rhyme or reason. Just, you know what? I'm going to make sure it's cured, so let me overcure it. And that comes with its own problems. And we're going to address those later too. So 73% of the dentists need to modify their curing protocols. And guess what? I was one of those 73% because I had known a bunch of stuff about curing and I thought I was doing it well. And, you know, I got a good curing lights, but in the end, I wasn't following all the information that was available to me. And with that, I was also over-curing restorations. Now you say, well, it's better to overcure than undercure. And I probably might agree with you, but I would rather have it right on the money, you know, especially something that I can easily control. That's the really important stuff. Knowledge is power. And in this case, we're going to go through things and hopefully empower you to cure restorations a little bit better. So one of the things we don't realize, because, you know, bonding pretty much just works and that leap of faith is really good. But with that, most dentists don't read the directions. Unfortunately, they don't read the materials. They, you know, the instruction that comes with the materials, they don't know what they're looking at. And just because it worked for the last material doesn't mean it works this time. And that's real important. So something, you know, you would look at all of these different materials and they may all require you to polymerize to a different number, different amount of time, you know, based on the, you know, quality of your light and the output of your light. So you really do need to look at the instructions. I don't care what material you're using. I don't care how you're doing it. You know, you need to make sure you understand why you're doing it, and that will definitely improve whatever you're doing. And it doesn't matter whether it's bonding right now, whether it's scanning with an intraoral scanner, you know, all of these things do matter. So again, you know, read those directions, because if you don't cure properly, you get problems. You know, you're going to get broken composites. You're going to get sensitivity. You're going to get, you know, recurrent decay. And I've never, ever, ever heard a dentist say that restoration failed because I undercured it. I didn't cure it properly, so that's why the restoration is failing. They will blame the composite. They will blame the occlusion. They'll blame the bonding agent, but they never blame the light. And the light is a critical part to all of these restorations. And you have to understand that and look to see why you may have a problem, not just, you know, have that problem. So what happens when you overcure? All right, you can damage soft tissue. It's heat. It's generating heat. And if you, you know, raise the temperature of the pulp too high, what do you get? You get pulpal necrosis. So, you know, this is something, again, that you have to understand, that just, you know, a little bit is good, too much is no good in this situation. So you want to be very, very careful about the fact that you just say, you know what, that's okay. I'm not sure how much time I should probably, you know, cure my restoration. So let me just go to this piece here and hope that it's optimal. And the ADA and the CDA, you know, they recommend you regularly test your light to make sure that you're getting the right output, because it is required. You know, it's making sure everything is running properly. I mean, we do it with X-ray devices. We do it with our cars and make sure they're tuned up. Well, this is the same thing with your curing light. So why is it important? Because all of the restorations, everybody assumes, okay, when we're talking about any of the dental materials, we want to put them in a dry environment. We don't want them underwater. We want to bond properly. We want to do all these things. And if you don't cure it properly, guess what? They'll have different properties and things won't function the way they're supposed to. And, when we don't polymerize things properly, we get reduced bond strengths and wear, and margins break down, and all these bad things start happening. And this is what the research is telling us. As your distance between the light and the composite gets greater, what do we have to do to compensate for that? How are we going to do it and still be able to maintain, the optimal properties of the composite and take into effect the soft tissue, the pulp, and everything else? So there's a lot of great composites in this world, all right? You're probably using many of them. You've tried many of them, but they only are great composites if they're cured properly. So you can take the best, materials in the world, the best bonding agents, the best, bulk fills, and guess what? If you don't cure it properly, you're going to run into problems. And we want to try and make sure we minimize that. So one of the things, and these are common questions, and you can get the answers here. You can look, you can find, if you want, take a screenshot of it or pick up your phone and just snap this picture, and go to that URL. But how long do I cure? Well, that's going to be based on a number of factors, but a lot of that is reading your instruction sheet for your material and reading the instruction sheet for your curing light. How do you know when it's fully cured? That's a bit of a leap of faith. You have to make sure that you're working within those instructions and make sure your times are within those and your output of your light is correct, and then you'll know you're cured. But there's no way for you to go up underneath that, composite. We want to make sure we can cure as much of it as possible. If we get the more conversion we get, the better properties we're going to have. Can I overcure? Of course you can. Curing too much just is generating heat to the tooth and the soft tissue. And again, we could talk about pulpal necrosis, and then we can cause post-op sensitivity, which can be from both over-curing and under-curing. And your restorations then fail. And, what else are we going to do? Will my light cure all the materials? That all depends. Again, back to the instructions. What's being used? What are the photo initiators to cure them? For the most part now, we are using, things that where the blue light will cure most, if not all, the materials. But there are materials that are using, different initiators that may be outside the wavelengths of your curing light. And the only way you're going to know that is to do your homework. So what makes for successful curing? Obviously, you get a good curing light. Most name brands are pretty good. But again, you want to, what are you going to use it for? Doesn't matter what it is. I always talk about, when we're talking about any type of technologies, what's it going to do? How's it going to do it? And what's the benefit? So you want to look at all of those things. But, most of the good quality curing lights out there are going to do the job as long as they're working properly. Are they cared for? How's it being used? Is there junk on the tip, or are you putting a barrier on it? Is the wavelength guide cracked, or is it intact? Those are the important things. Operator technique, and we're going to get into some of that a little bit later, but who's doing it and how well are they doing it? How well trained are they in doing it? Just because you can get the outer layer cured doesn't mean the deep layers are curing. What about the characteristics, C factors, and other parts to these restorations? What's happening with composite as we're doing all of these things? Those are things you have to be aware of and take into account when you're curing, especially now that we're using bulk fill materials. How are we assuring that, we're getting a good cure? And then what are the energy requirements of the material? And that comes, again, back to reading the directions. And to, what's it going to take to fully cure the material without over curing the material? Because all of these things are going to, are going to impact whether you've got a successful restoration or a failure. The problem is, in many cases, it's not an immediate failure. It could be what I'll call a long-term failure. As we saw before in the research, 23% fail at 2 years. I mean, to me, that's unacceptable. Plus, it's just not good for a practice. So what are the things that influence light curing? Well, obviously the size of the curing tip. So you're going to have to know, how much energy is being put out and where it is in relation to the tooth, the angle that you're holding the curing light, the tip, and where it is from there, how far it is from the actual restoration, what type of light, the exposure time, how much time do you give that to cure, and even the composite color will greatly influence the amount of time that you need to cure a composite. So I took these were in my office, and I wanted to show you that they're both 8 millimeters, but this SDI radii has this nice orange piece on it as a protect your eyes, but it makes the tip look bigger than it really is. So with that, don't be fooled. The size of the tip does matter. And tip sizes in general, there's a tacking tip, which is 2 millimeters, it's too small. Most of us have 8 millimeter tips or 10 or 11 millimeter tips, but again, it's based on, size of the tooth. And, 13 millimeters will do a veneer, an onlay, crown, but the 8 millimeter tip is what I have in my office. It's what I just showed you, and it can be used quite effectively in all areas of the mouth, but you have to take into account, what that is. And then we get to beam uniformity. Are there hot spots? How much energy is being transferred from the tip? These are important pieces to the puzzle, because not every curing light is going to get you the maximum amount of illumination, radiation, not, in that radiation of light into where you want it to be. And this, contributes to the factors of people deciding that I'll overcure it to make up for the fact that, it's what I do. And if you look at the bottom there, you've got a large 10 millimeter tip, which covers a big chunk of that molar. But guess what? If you're doing an MOD, it's not going to work for you. So you have to overlap. And the same thing with that 8 millimeter tip. You have to understand that the average molar is about, is 11 to 12 millimeters. The average premolar is somewhere around 8 millimeters. So you may need to do it, twice, but you're going to have to take a break because you don't want to over radiate the tooth with it and cause an increased heat. Distance is another thing. When we look at this, it needs to be 3 millimeters from the composite. Well, if you've got a big high band and a ring sitting on top of it, how far are you from that composite? So you have to take those factors into consideration. And as we get further away from the tip of that light, you're going to lose intensity. And where's the most important part that you need to cure in a class 2 composite? The bottom of the box. So if you're layering, it may not be as big an issue, but if you're doing bulk fill, that's a completely different issue. All right? Because you need to make sure you're able to get enough energy down to the bottom of that box to cure that composite. And again, overcuring just raises pulpal temperature. All right? So this radiant exposure, as it's going up, you get these potentials for temperature rise. And, obviously, a little too much of that, you're going to kill off pulps. Not a good thing. Again, the size of the tip, you got to cover the tooth. Where is it? Again, in this situation, you need at least 2 swipes for an MOD. Always keep that in mind. And it's the ability to cure the composite is directly proportional, all right, to how much power is coming out of that tip, all right, and the distance you are from that tip. So, can you get to the bottom of the box? And here's a routine, nice little slide here that I think shows a lot of that. I mean, you're looking at 1 millimeter above that cusp tip, and it's 6 millimeters to the bottom of that box. Okay? Think about that. And now if you're even above that, how well are you curing that? You know, in a bulk fill situation, that's something to think about. Because when you look at that coming down, what's that beam of light look like? You know, that's a big deal. You know, how well culminated is it? You know, or what's happening with that beam of light? Do I need to overlap? Because if I got this big broad MOD, I mean, look at that. I may get it all to, I get it hard enough that it looks like it cured, but what's happening, you know, at the bottom, what's happening at the sides? Because, I mean, here's just another one with 3 lights. You know, which one's going to do the better job getting to the bottom of the box? Well, it depends on the depth of the box. It also depends on the distance. And you need to be totally aware of these things. All right? Because when we look at some more of this, you know, in this research, you know, we look at all of this and we say to ourselves, well, what does it mean? And it's all of this stuff is just something that we have to take into effect, you know, and when we're doing this. You know, one single time, one single value doesn't give us all of the answers. You know, if the deeper the restorations and they're not properly cured, you're gonna have post-op problems. It just comes with it. And even when, you know, we look at some of these bulk fills, and I know some of the research, you know, they'll say 4 to 5 millimeters of depth of cure, and that's fine. I've seen some of the research say 7, 8, or 9 millimeters are even being cured, but you're never sure. And, you know, that's really the piece of the puzzle, is making sure we get to that. Because again, here's some more, looking at these hot spots and everything else, and look at the distance as we get to 8 millimeters. You think that's a lot of energy getting to that composite to cure it? I don't. You know, and see here, you know, where we started at 1,400 milliwatts per centimeter squared, right on the cusp tips, but as we get to the bottom of that box, look at that. You know, it's almost, it's 40%. So, you know, at certain depths, even if it says 3 and 4 millimeters, it'll cure, you definitely don't want to push that, you know, because you're going to get a better cure as long as you stay within those parameters. You know, here's a little more visual on the same type of thing, but here's 3 curing lights. And if you look, you know, the one that's got the most output, the highest at the beginning, has got a pretty low one when you get to 8 millimeters. You know, and you can see here where things start tailing off, and you have to sit there and go, okay, you know, here, the blue phase with most of the energy is really great up until it starts getting to about 5 millimeters and starts tailing off. These are important things to know. And as the distance between the curing light tip and the restoration increases, the curing energy decreases. And this is just, you know, it just exponentially goes down, and it's just like here, you know, you got that hose and it's, you know, set on blast on that jet tip, you know, you're going to get a lot more energy delivered to whatever you're trying to watch versus spraying the thing all into a cup and, you know, watch it all flow all over the place. You know, which one's going to work better? You know, again, depending on your techniques. So all the things becomes technique, curing light, the technique with the curing light, the bonding, all of these become part of it. You know, you have to understand that. And the well-collimated light is going to do a better job than the broad one. Okay? It's just the way it is. You know, that ability for it to just get where, you know, the most energy down to the bottom of that box. That's the goal. I mean, that's what we're looking for. That's what we're trying to achieve, is that good cure. And we want to make sure with whatever we're using, we get to that point. You know, here's another example of being collimated versus not collimated. You know, there you go. I mean, you know, I want that. I don't want that big broad piece coming out, because again, when we start looking at, you know, restorations and depth, and 4 millimeters here, 8 wide, 2 millimeters across, I mean, we have to understand what the tip of that light is doing. And in many cases, people will just take that tip, place it in the middle of the tooth, and assume because everything got hard on top, you know, it's all cured. And the reality is it may be cured on top, but what's going on underneath? And did you get it there? You know, the the angulation of the light, you know, you want to try and hold it, you know, perpendicular to whatever you're using. You want to make sure you're getting, you know, straight line access as best you can, because as you start putting an angle to the light, you're going to get reduced light output. And here's a perfect example. I was able to show this when I photographed it. You know, you can see, look at that nice round circle, and it goes down real well. This is the same light. All right. But as soon as I start turning it on an angle, what happens? We get this ellipse, we get a hot spot in the middle, and it starts decreasing significantly. You know, you see that those really hot spot in the white, and then it gets blue, and then it gets purple, and then it gets, you know, to that other blue. But you can see the difference in that. And that's what you don't want to do. So you want to try and hold it as straight as possible. You want to be as close to the tooth as possible. All right. That's another piece of the pie. You know, one of the things when I talk about poor curing position, and I've seen it in my own office, I've seen it, you know, being done, I've seen it in demos, is, you know, no one wants to look at the curing light. So I call it, you know, they hold it up and no one's looking, and the thing starts drifting, and the arm's moving, and everybody doesn't know where the tip is. And eventually it comes back to the center. And that happens whether the dentist is doing it. It happens whether it's the assistant holding the light. I've seen it happen all over. All right. So you really want to get as close to the light, to the source, to the composite light source, to the composite as possible. You want to hold it steady, and you want to hold it there, because if you start moving it around, guess what happens? You start losing depth of cure. So again, it's really important to do that and make sure you're, you know, in the best possible position to cure that. And if you're not, then you need to take into account that you may need to cure it again. Not over curing it, okay, but just curing it properly the first time, even though your numbers may be slightly different. So with that, again, you know, we're looking at what effect does this have? Okay, you can do things differently, and they're going to deliver different amounts of energy to the tooth. You know, this is the proper way to start curing this. All right, you want it down there, you want it on top of the tooth, and you want to be able to deliver that light energy to the composite. We can also go in from the side. All right, now if there's that distance is maybe greater, all right, that's something else to take into effect. But you're also then, you know, angles, you know, it's going to decrease your light energy getting into the tooth, because as we showed you before, you know, you get this ellipse, and the ellipse has less power than that circle. So with that, you know, what other things happen? All right. And we've seen the white lines, and everybody's trying to come up with reasons for it, and we bevel for it, and we do this and that, but fast curing isn't going to give you white lines. You know, it's not going to give you increased micro leakage, or it's not going to shrink your composite, all right, more than just regular curing. You know, these are things that we have to be aware of. So, you know, we're not going to cause, you know, increased shrinkage, but again, you know, how fast are we doing this? That's why some people are, you know, and I have a light that pulses. And, you know, there's some benefits to doing that, but, you know, some people are in a different camp, and I'm not going to say, you know, one is worse than the better or worse than the other, but it's something to, you know, to think about. You have to make your own decisions. All right, when it comes to that. The white lines, you know, we've seen the whole different discussions about them. Obviously, they're less of a problem in the posterior than they are in the anterior, but and there are ways to try and, you know, mitigate them, but it's not via your curing light. And micro leakage can be from a whole bunch of things, but if you don't cure, you know, properly, you're going to get micro leakage, you're going to get staining, you're going to get recurrent decay. Just comes with the territory. What about darker composites? Well, the darker ones are going to take more time to cure. Just makes sense. You know, when we looked at these, so here was a bulk fill from Heraeus, you know, and you look at the Compule, and they're much more translucent, your bulk fill materials. The whole idea is to try and get light through the material to cure better. Well, yeah, totally translucent composite would do that trick very well. But, we don't want to use those. Why? They turn teeth gray. And, those were the early bulk fills, and people didn't like them. They weren't really indicated in more of an aesthetic zone. In, maxillary premolars would be the case. But you want to consider, if I have an A4 composite that's darker, it may take more energy for me to get that cured than maybe an A1. Something to think about. And then we get these budget curing lights, and I've tried them over time. I've had a few. They've all wound up in the garbage can. Because I wound up having problems. And there's really no defense for them. They're cheap, okay? Do they seem to work? Of course they do, right? But they have some problems that go with them. What's the quality of the light? Are there hot spots? Are there things that are going to make it look like it's cured, but it's not? And, I've heard people tell the stories about, well, I can put one in every room, and when it fails, I throw the thing out, and I still haven't paid for the, for the quality light. Well, listen, we all use lots of composites, all right? Every day, somehow, some way, we're using some kind of composite materials to get us to finish up our restorations. Well, you know what? In many cases, the manufacturers of these lights also sell composites. If you order a big enough order of composite, in many cases, they'll throw in a light. So, ask. It's that simple. Ask them. Okay, I ordered $2,000 with composite, and you gave me a $1,000 curing light. Thank you very much. I'm going to use both, and I want to make sure I do. And what I'm going to do is going to be much better than trying to save money on a curing light. And this is another article, which basically says there's no accountability. You don't know what you're getting. And ultimately, if something bad happens, it can be tied back to you and tied back to the light. So one of my cheap lights that I tried many years ago, which I think I got on eBay, patients would complain if I didn't give them anesthesia, which hides a lot of the issues, by the way, that it would get hot, that I'd be burning their gums. Well, yeah, that light wasn't doing well for me. Went in the garbage can. One way to check a light is actually put it on your thumb. Turn it on. Does it burn? Does it get hot? Figure it out. This is the kind of thing that's pretty simple. But if it's going to burn you, it's going to burn them. And if it's hidden by the fact that they're anesthetized, that still doesn't mean that you're not overheating the pulp or causing some issues to the soft tissue. So, be very aware of that. The claims become just that. They're claims. I mean, what do they look like? Okay, I've got 1,800, milliwatts, but what do I really have? What's the size of the tip? That matters, because all of these things, how well columnated is it? All of these things apply. So, just because the number looks good or what they tell you seems okay doesn't mean it matches reality. Almost anything we buy, we're being sold. And no one's going to tell you the downside of what they're selling you. They're only going to tell you the upside. So we've got all these great numbers, and we go, okay, that works. Sounds as good as the one that's $1,000. I'm going to save myself a lot of money. You may not be saving yourself anything, because think about it. If you have to redo a couple of restorations because of it, or a patient's tooth now starts going south and complains that, doc, it didn't hurt until you put the new filling in, and we'll blame something. But guess what? We never blame the light again. We never think of it that way. Well, it's your tooth got beat up again, and now, the nerve went bad. You can only put so many fillings in the tooth, blah, 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 blah. And all of that's true. But we never talk about the light as being possibly one of the causes. Again, we're looking at beam profiles and what they look like, and how the energy is distributed to those, in those teeth with this light. And, again, it may cure, and it looks like it's cured, but how well is it cured? that's really it. And this is what we're looking at. What's the beam uniformity? Think about it. I mean, they're not all the same. And this is the thing that you're requiring yourself to understand, that how is it distributed and what's ultimately going to be your problems. I mean, if you look at B there, and you just put it on the top and it'll cure the whole top, but you really didn't get the cure that you need to properly get the material to cure to the point that, hey, you know what, this is done right. And if you can see all of these things, what's being missed and not, just even by the size of the tip. What am I getting? Where am I going? And when you really think about it, what's the cost of the light, over time? And Blue Light Gate had this study, and you're looking at, it's negligible. That $20, it's 40 cents. We waste more than that. Your bonding agent, which is probably one of the most expensive liquids in the world, and if your assistants are like mine, sometimes they're not like my bartender. I don't want them to over pour. They pour out more bonding agent than they should, and it all gets wasted, and that stuff's expensive. This isn't, compared to what you're doing and what you're charging. So why cheap out here? It makes no sense to me. So again, you want to stay, in these parameters where, hey, this is what I want, this is what I need, and trying to save a couple of bucks on a curing light really isn't the way to go here. It's just not, because the total cost for it is just really small. It's not something that you have to keep replacing. It's not a disposable. It's something that we're just looking at on a general basis and say, hey, what is it? Well, it's a one-time expense, or like I said, if you buy enough composite, they'll give it to you. There's always a special. Always ask for the show special. Somebody's going to have something. And again, it's something to think about. And then barriers. This is something that, I thought about. I never really thought about, because they were clear, and how they're put on matters, as you can see, like on that lower left. You also have, some of them are more opaque than others. And when I started checking some of them with and without, when I started checking some of my lamps with and without the light, it was kind of eye-opening that I lose about 100 to 125 milliwatts of power just by having the actual manufacturer's sleeve on the light. And the reason you want those barriers is because you don't want things accumulating on the tip. I don't want composite on the tip that's gonna, I have to chip off. I don't want to scratch the tip. This is the last part. This is the piece that's going to allow that focus of that beam to get to my composite and properly cure it. I want to keep it as clean as possible. But I never thought that I could lose almost 10% of my light by the fact that I just put the barrier on. So, quality barriers also matter. It's some piece of the puzzle that we really don't think about, because it's just part of what you do. Your assistant puts the barrier on, and you pick the thing up and don't spend a lot of time looking at it. And again, you just go to the mouth, you turn on the light, just like we said, and we cure it, and that's the end of it. But again, how much are you losing if you're using cheaper barriers? And it's really easy to check. If you've got a radiometer, just put it on. All right, look at the two values and just realize. Now, will that make a difference in what the times and everything else that you may need to cure it? No, it may not make a difference in it, but it's something to be aware of. Okay, you just, again, take things into consideration when you're doing it, that, great, I've got a 1200 milliwatt light, and it shows me 1200 milliwatts, but guess what? You put the barrier on, and now you have an 1100 milliwatt centimeter squared light. Well, again, does it matter? No, but ultimately it could be based on the depth, because it's how much energy is going down that tooth and how well collimated is it and everything that goes with it. So each piece of this is important, and we have to understand that. So, the basics were always a radiometer. And with that, we would put the tip right on it and we get a measurement. Now, that sounds all well and good, but you know what? It's not necessarily realistic. Maybe on an occlusal composite that's 4 millimeters in depth, that matters. But when we start looking at the real world and we put a barrier on it and we move this thing up from, right on the composite to 2 millimeters or so above it because we've got a band on it, and we're trying to get that bulk fill down, and the thing is really at 6 millimeters or 7 millimeters, what are we doing? That's why in many cases the bulk fills on a class 2, they recommend not only curing from the occlusal, but coming in and curing from the interproximal. And the whole idea is to try and get that energy, as best we can into the box of that class 2. Now, one of the things that we have to take into mind are, how many times and how quickly we heat up a tooth. And we're going to get into that, just in a couple more slides ahead, because it's part of the discussion. And knowing, and this is part where I come into the 73, where I change my parameters based on information that I got, because I did get one of these checkup devices from Blue Light Analytics. I kind of call it a radiometer on steroids. It's a superhero. What it's going to do is a whole lot more than just give you a number, because what it does is it actually looks at the output of the light. It attaches online. It goes online. This is an app that sits on your, on your phone, and you tie it to the Bluetooth to that little, square. And what happens is it talks back and forth to the internet. And there's a whole database on all different materials. So you're not going to just know what you have to do for your light, because it's going to give you that. It's going to give you the radiance numbers, but it's also then going to tell you how long you have to cure each and every material. And that includes your bonding agents, your, composites, different composites. Most of us don't have just one composite in the drawer. We got a whole bunch of them, different manufacturers, all of these things come into play, and they give us different numbers. And that's the key here, is it gives you more information distinctly to your light and times and everything else that goes with it. So, these are mine, okay? These are from my office. I have a Demi Plus, I have a Velo, and this is a corded Velo. But I just want to show you a little bit of what the differences were. So on this Demi Plus unit that I first put in, we got almost 1,300 milliwatts per centimeter squared. And you look down at the curing times, and if I was using Vocos and Mirafusion Extra, all right, in a 4 millimeter increment, it tells me I need to do for 20 seconds. Okay. And if I was using Pentron's Artiste, it's 10 seconds for 2 millimeters. So you go, well, okay, if it was 4 millimeters, it would be the same 20 seconds, but the recommendation is not to put 4 millimeters in with that, because it's not a bulk fill material. All right. Now, looking at those same materials over on the other side, we notice that, there's a difference in the power output. All right. But it's still telling us that we can cure it for the same amount of time. All right. With that, here's another one, which was from the Demi, which was a little bit more of the materials I had. There's a Takayama. Well, okay, that's 13 seconds versus the Pentron, which was 10 for the same material, for the same light output and the same depth. Omnichroma was the same 13 for 30 millimeters versus 4 millimeters for the Admira Fusion. So again, they're different materials. They're requiring different curing times. The bonding agents were all 5 seconds. Sonic Fill was 10, but then you have to add the buccal and the lingual. So now it's 30. All right. in my Vicilis core material. It's 20 seconds, 2 millimeter increments. Thank God it self-cures, okay? But these are the things that, it started opening my eyes in terms of, what's going on and how's it working and what's it doing? And maybe I need to change my protocols. And that is really an important part is, having all of this knowledge allows you to make changes based on your materials. I mean, look, if you see, I got an 8 millimeter tip on one and a 10 millimeter on another. What's the output? Supposed to be, where are we? And then we come to what I call the important numbers, the potential heat concerns. So at the higher numbers, all right, it's 14 seconds. On that Velo, it's 16 seconds. But why is that important? Well, I show you this slide. And with this slide, I would routinely say, okay, there's an option there for 20 seconds, and I used to do a 20-second cure. Yeah, I would overcure, all right, depending on the situation. But at 14 seconds, I have to think that maybe I'm overheating the tooth. So how do you compensate for that? Well, one of the ways to do that is to cure it for 10 seconds, give it a few seconds of rest, and then go back and cure it again. So if I'm using my Evoco Admira Fusion Extra, I would cure it. I would cure it for 10 seconds, give a couple of seconds rest, and then cure it again. All the while, I'm trying to protect the pulp here from, you can take a tooth that may be sitting on the edge, between, becoming a problem or not, and you may push it over the edge with a little bit of light. So where I used to, like I said, I used to leave the timer set at 20 seconds. Now I don't. I set it to 10. And with that 10 seconds, I will modify my curing regimes around that 10 seconds. Why? Because I'm trying to play it safe. I don't want to be one of those people who overcures. I don't want to be one of those people that undercures, and that's a real important part. So with this, I got a lot more information about my curing light. It's attached to a database of millions of materials that you can then look at and say, what's the optimum curing? And then once I know that information, I can then make adjustments accordingly. Maybe I don't have such good access and I can't get that tip the way I want it. How do I compensate for that? Maybe do I turn it down to 5 seconds and do, 3 5-second cures, because I can kind of manipulate the tip around better than I could with just one big 10 or 20-second cure, hoping that I'm going to get, more power and light down to the bottom of a box or the depth of the restoration. I mean, these are all the pieces of that puzzle that, we need to be aware of. So, tonight, that was the overview. I hope it gave you some good information as to what to do and what to look for with your curing lights, and how to make better cure your restorations, which ultimately give you a better restoration, and your patient has more, more things to do. All right, I got questions coming in. Let's see. Other than lost time, what are the disadvantages of overcuring? Obviously, we just went through that. Overcuring can cause soft tissue damage. It can cause pulpal damage. And then again, if it's not in the right position, all you're doing is pushing light and heat at a tooth versus actually curing the areas that you want. So again, you're looking at problems by overcuring. Is heat still generated after the composite cures? No, it becomes inert. The heat, for the most part, is the chemical reaction along with the heat from the light, which I believe the heat from the light will give you more of an issue than necessarily that generated by the chemical reaction within the tooth of the composite. And the same thing again, what happens if you overcure? Well, we just went through that. Again, you're going to have problems. Could you use air to help cool the tooth while curing? Absolutely. All right. One technique will be, if you want to use extended times, is to have your assistant, if you're the one holding the light, or the reverse. If your assistant is holding the light, you can take an air, syringe and just, fire some air over it. That's definitely going to cool it, and is an effective method to reduce temperatures on the tooth and soft tissue, while using your curing light. That's an excellent question. So next one. So I should not buy a radiometer. Well, that's not what I said. Now you can use at the bare minimum, you should have a radiometer. This blue light analytics device is a radiometer, but it's attached to the database, and it's going to give you a lot more information that you're going to be able to then use smartly to modify and deal with all the situations, because you're going to have the information that you need to properly cure your tooth. So how does the white line form from the edge of the composite? And let me see if I can get the rest of this. Let's see here. Trying to make it bigger. I don't see the rest. I can't get the rest of it. Just as how does the white line form? There's a lot of discussion about how that white line forms. Some of it has been talked about as contraction. When you get the shrinkage of the composite and it pulling at the prisms of the enamel. And have I ever experienced it? Yeah, of course I have. But again, it's not something I see on a regular basis. A lot of people recommend beveling. It's just, comes from the territory of putting in a composite. What do you think of the small adapter tips to narrow the light that gets placed in a class 2 box? Well, yeah, so what you're going to get when you put a smaller tip on and you want to get it to the bottom of the box, yes. But you also have to realize when you get that smaller tip on there, you may also be increasing the amount of heat that's generated, because again, it's going to be great for curing it, but again, it's small. Can you get it down there? And I'm going to say it's definitely better than sticking it up 2 millimeters, above the tooth. Absolutely. So if that's part of your technique, yes, I'm thinking that you take a nice 5-second cure on many of those composites initially and just put it down in the bottom of the box. I think that would work quite well, and you should be fine with that. But then again, at some point you got to pull that tip off, pull the barrier off, pull the tip off, and so it may not be the best workflow for you, but yes, that would work. All right, now there's the $1 million question. As a new dentist, what curing light would you recommend? I'm not here to recommend a curing light in and of itself. The research can be done online. I would tell you what I would recommend is that you stick with a name brand. All right. As part of Best of Class Committee, this year we did pick Velo. Velo has been a top composite curing light for many years. The Ultradent folks do a great job with it. It's tough, it's durable, it's got good output. You have to also remember when you use that, there are different settings on it, some of which can bring the numbers up quite high in terms of output, but also generates a lot more heat. So again, what part you're using for it, how you're using it, you got to read the directions. But Velo is one, Blue Phase is another, the Demis from Kerr are good, but there's all name brands. I would stay with a name brand. I wouldn't be going to eBay or Amazon buying an off-brand. Okay, and let's see what else. Do you like booster probes? They have more scatter. Straight probes are better. Well, here's the thing. If I'm pretty much tell everybody stay with the normal tips. We're trying to get more output from what you've got. Stick to what we do, and that would be it. That would be the important part. Lots of things become gimmicky. I just think you stick with a standard tip, and that would get you what you need. So then the question is, most composites cure at 20 seconds. I'm going to try, let me go back here for 1 second, and let me see if I can get back there real quick to that. Let's see, let's go back. So when you say that, where are we with all of those things? Take a look at this slide. where you're saying most. Well, here, the Takayama Estelite Sigma Quick is 13 seconds. Sonicville is 10. They're gonna be different, and it's based on the light and the output. So it's just something you have to be aware of. And I think that's real important, is being aware of what we've got and what you've got, and the difference between just buying a radiometer and getting something like checkup from Blue Light is that you get that additional information, that you now have the ability to look at all of those pieces and know what you're actually doing. So that to me is a huge piece of that. And one of the reasons that I found the information to be quite enlightening, and something that would definitely have changed and modified my protocols. So I jumped myself into that 73%. I used to be a 20-second cure guy. I was. You know what? 20 seconds. More is better. Well, it's not. 10 seconds for bonding agent. Okay. Well, in most cases, 5 is good enough and where you want to be. So, it's not always more is better. I mean, we've gone through that, with like medications, 1 pill's good, 2 pills are better, 3 pills must be better than that. It doesn't quite work that way. So, I think trying to stay within the manufacturer's directions as close as possible, knowing what you need to do when you have to modify those and what the benefits are to doing that, are really where you want to stay. Curing is not one size fits all. It's not just go to the curing light, hit it for 20 seconds, and think everything is fine and dandy. There's a lot more that goes into it. Hopefully I, imparted some of that to you today. Can lights really cure through the CEREC Emax crown? Yes, they can. They're not going to go through zirconia very well, all right, but they definitely were going to pass through Emax. That's how you're going to bond it on. So yeah, you're definitely going to do that. I mean, some of the resin self-etch resin cements, you cure the excess and chip it off real quick. All those things, but yes, no, it definitely is going to go through an Emax crown, whether it's done with a CEREC or done through a lab, doesn't matter. I want to thank everybody for coming in here. Have wonderful holidays, and thank you for your time. You could have spent it many other ways than this, and I appreciate that. Hopefully you learned a few things, and you'll do better restorations because of it. Again, happy holidays. Thank you very much. Bye-bye.